to today's webinar, Ercp 101. A few housekeeping items before we get started. All attendees are on mute, so during the presentation, either jot down your question and select the hand at the bottom of the screen, and your line will be unmuted during the Q&A session. If you're listening by phone, you will not be able to unmute your line. Therefore, you'll have to use the second option, which is select the Q&A at the bottom of the screen and type your question, and then we'll answer your question during the Q&A session. Please keep your questions out of the chat section. That way we can keep all the questions in one place to make sure everything is answered. The handout was sent out earlier this morning, and it was also sent out yesterday to those that had registered before today. Today we've got Kathleen Miller on the phone to do the presentation. You should be able to see her screen. And Kathy, I think we're ready.
Okay, thank you, Lynn. Just always we have the disclaimer that indicates that the course is current and all the information in today's webinar is current as of today, March 10th of 2020. And just remember that anything can change at any time, even half an hour after we're done with this. As always, you want to make sure that coding policies and guidelines are checked with each payer and updated as frequently as possible. So we're going to talk about ERCP, and the objectives for today is, first of all, to discuss medical necessity, which is your key to economic success. If there is no indication, if there is no significant finding, then medical necessity is not supported, and a payer has the right to either not pay or potentially to recoup money. We're also going to talk about the anatomy of the biliary and pancreatic system, since this is ERCP 101, and ERCP information on scopes and procedures, and last but not least, case studies. So let's go ahead and get started. So medical necessity, this is an area that's being looked at very closely by payers now, and of course there's 3 guidelines. Without medical necessity, you won't get pre-authorization. We have seen a lot of pre-authorization requests for EGDs in the past year. And, of course, ERCP is in that family. And so, therefore, oftentimes we do need to make sure that our documentation is there. And most of the time, before an ERCP is scheduled, our physicians, our providers will also see these patients. So you should have a medical record to draw information from. Without medical necessity, services won't get paid. And without medical necessity, recoupment of previously paid services will be obtained by payers. And technically, the code that supports medical necessity that you submit on your claim, that you give to your pre-authorization and utilization review staff at the payer in particular, is your ICD-10 code. So if that is not specific, that is not clear, then technically the payer has the right not to pre-authorize the service. You may get that as your denial reason on your EOB that says claim lacks medical necessity, and that means the diagnosis code. And same thing for our recoupment. Sometimes outside auditors get pulled in to review claims for the payers, and one of the things that they look at is specifically the medical necessity part of the claim. And in order for those services to get pulled for review, oftentimes what's on the diagnosis code is what triggers a review. So diagnostic procedures require documentation of symptoms and abnormalities to support medical necessity for diagnostic endoscopic examination. So again, that's one of the things we need an indication on there. So if your doctor's got elevated liver function studies, that's not really good enough. We need to know what was elevated within that family of enzymes in particular. Pre-authorization and verification of eligibility has to be done at the time of scheduling, or services may not be covered, and leaving the practice or the patient literally just holding the financial bag. So remember, you're including places of service. If down at the hospital, what's the medical reason? And we are seeing this. United Healthcare was one of the first payers beginning November 1st of last year that started looking at the place of service. And one of the issues had to deal with, why are you doing these procedures in the hospital when they can be done in an ASC? And yes, the RCPs are approved for ASC services. and I know most of you listening here probably don't do ERCPs at your ASC, but if you do, then that would be a question to a payer is, why are you doing them in the hospital setting? And your answer should be comorbidities. All right, and that should be supported by your physicians as well. A statement such as, because of ASA 4, et cetera, this patient cannot be safely done in the ASC, will be done at the hospital. Now, for those of you that don't do ERCPs in your ASC, simply because you don't have the equipment there, that is your answer. We don't have the equipment to do ERCPs at the ASC, and that will override it, and they will usually still approve that. All right. Also, when you do pre-authorization, if you have to give the payer a CPT code or codes of what you might be doing during the procedure, remember that some payers will not go retroactive and just go ahead and pay for service that were not pre-authorized. So recommend that within the ERCP family, and there are not a lot of codes within that family, wouldn't hurt you to pre-authorize every single ERCP code that could be done during that procedure, just in case your doctors end up doing some of these. And this happens. It happens sometimes. They don't know what they're going to do until they get in there. Anatomy of the biliary and pancreatic systems. So we're going to talk about the biliary system first. As you can see on this slide, we have an actually black and white version, which you can see behind, or actually it's going to be in front of the liver, and in front of the pancreas lies the esophagus and the stomach and the small intestine. All right, so I'm just kind of going to highlight this tree, and this is a tree. It's called the biliary tree. This duct goes to the right hepatic ductal system. This one goes to the left hepatic ductal. This little guy right here is a cystic duct, which leads and drains the gallbladder, and it hooks into the common bile duct. So when you get through the ampulla, where this little area is that I'm circling, you can see that off to the right is the pancreatic ductal system. All right, so again, this is what your physicians are looking at when they do an ERCP. So the liver, it actually is the largest gland in the human body. That's kind of a trivia question. What is the largest gland in the human body? But that's not what it gets asked. Is what's the largest organ in the human body? And I've been fooled on this before. The organ is the skin, but the largest gland is the liver. And it lies below the diaphragm. It produces bile and excretes bile that is responsible for taking down fats. It drains into the small intestine, and some of it's stored in the gallbladder. It's responsible for metabolism. It produces coagulation factors. It breaks down hemoglobin, toxic substances. It is responsible for metabolizing a lot of drugs. If the liver doesn't metabolize drugs, the kidney does. So one or the other. The liver converts ammonia to urea, and it also stores multiple substances, vitamins, glycogen, iron, copper, etc. Pretty functional organ, and responsible for a lot of different functions within the body. So some of the diseases that affect the liver are ones that we treat. So cirrhosis is a formation of fibrous tissue in the liver, and actually it replaces dead liver cells. So what kills the liver cells? Viral hepatitis can, alcoholism, and also toxic chemicals. One of the chemicals actually are drugs, and Tylenol is one of the most toxic drugs you can have. So cancer of the liver, sclerosing cholangitis, hepatitis, and these are all conditions that we diagnose and or manage. The pancreas is one of the organs behind the abdominal cavity. It's in the rear, the retroperitoneal area. It's behind the stomach, and can also be behind the small intestine, the first part, the duodenum. It's often described as having three regions, which it does: a head, a body, and a tail. And so the head is pretty well it pretty well goes to the second portion of the small intestine. The body of the pancreas is at the level of L2, and the tail is towards the spleen. And like I said, it pretty well is behind the stomach. It secretes hormones that regulate blood glucose levels, and it produces enzymes to break down digestible foods such as amylase and lipase. The gallbladder is a little organ, pear-shaped, and it stores bile, otherwise known as gall, until the body needs it for digestion. So again, when food containing fat enters the digestive tract, it does stimulate the secretion of an enzyme called cholecystokinin, as the food moves from the stomach into the small intestine. All right, so biliary colic occurs when a gallstone blocks the common bile duct, and acute or chronic inflammation of the gallbladder causes abdominal pain. And choledocholithiasis, all right, is when there is an obstruction in the common bile duct, and often the patients develop jaundice, which can back up and cause damage to the liver. This is the most common reasons we are called to do ERCPs for our physicians. ERCP information, we're going to talk now about scopes and procedures. So the very first slide here takes a look at the scope and where the biliary tract lies in conjunction with the small intestine. So as you can see, this scope is pretty thick. And off to the side, that blue cannula goes into the ampulla, and then you can see this catheter in particular is going up into the common bile duct. Right. You can also see that there is no way that this black scope could go up this tiny duct. All right. So when your physicians do ERCPs, this catheter that threads up into the duct also is the mode of injection for the contrast in order for your doctors to view the common bile duct, the liver structures, as well as the pancreas. And the next little slide here pretty well shows you some detail. All right, this is the scope itself. So when you look at your gastroscopes and your colonoscopy scopes in particular, that the openings for the air and the camera and the light and where the instruments come out are not off to the side. They're at the bottom. All right, so you can actually see that this is a very different scope. It goes off to the side. And here are two different ERCP photos. This one on the left, this one on the right. To me, the one on the right is clearer. You can actually see after contract has been injected that you can actually see the ducts. You can see the tree, the different branches in there. You can also see the cystic duct, which drains the gallbladder. And then it goes to the left of the patient is the pancreatic duct. So the term is endoscopic retrograde cholangiopancreatography for ERCP. And most common procedure we do is ERC. Pancreas is only injected when necessary. Most of the time the physicians don't bother the pancreas unless needed. And the collection of specimens by brushing or washing is included in reporting of this code. It's included in the base code of 43260. So probably one of the major issues that we answer a lot of questions to is a balloon sweep was done. Can we bill for the dilation? Or we did bill for the dilation. No stones were removed. So can we bill for stone removal? Well, the answer is no. All right. So if you haven't observed an ERCP procedure, you should. The insertion of the balloon catheter and the inflation is often done just to keep the contrast in place. So just because the doctor inflated the balloon doesn't mean there was a dilation. Just because they dragged the balloon down the duct doesn't mean necessarily you were doing stone extraction or debris removal. That was just a way to get a better look as the contrast then comes down with the catheter. So the inflation of the balloon is not billable unless there actually was a stricture that was dilated. And if no debris, sludge, or stones are removal, you cannot bill that as stone extraction or debris removal. Only would be considered part of the standard code of 43260, which is your base code. And if you're unable to cannulate and inject the duct, no other procedure is done to the biliary system, you're going to report this as 43235. And that was with the last update that we had on ERCPs in 2014. Radiologic supervision codes may also be billable if the radiologist does not participate in the interpretation of ERCP and does not dictate a radiologic report. All right, now this was revised in 2019 in the CPT book that a separate report or separate paragraph indicating the findings should be included in ERCP report. You don't have to have a separate report, but there has to be a static image kept in the record in order to bill for the radiology services. Fluoroscopy is always utilized with ERCP. You cannot do it without it. So the 76000 code, which is kind of the base code for fluoroscopy, is already built into the value of the 43260 codes and cannot be separately reported. So 43261 describes an ERCP with biopsy. And since January 1st of 2018, it's bundled in stun placement or replacement, dilation codes, ablation codes, etc. So in order to build the biopsy codes with these procedures, the biopsy has to be in an area separate from the stent placement or the dilation zone and separate from the was ablated. This kind of came out the same way that when the biopsy got bundled into your esophageal dilation codes. It's the same principle. It has to be outside of the dilation zone as well. 43262 describes an ERCP with sphincterotomy. This is where the sphincter of Oddi is incised to allow flow of bile. And either one, you could be both of them, you can do one of them, or the sphincter controlling the pancreatic duct may also be incised. If both are incised, both can be billed. The second one would take the 59 or the excess modifier, depending upon payer policy. Sphincterotomy, though, cannot be billed when stent placement or replacement is done in the same location, and it can't be billed separately with a sphincteroplasty. So again, since 2014, if we do a sphincterotomy at the time we place a stent or we do any type of dilation, it's all considered part of those codes and not separately billable. And this is the sphincterotome. All right. ERCP with pressure measurement of the sphincter of Oddi really does not get billed. I don't even see it described by most physicians. 43264 is ERCP with removal of stones. It includes a balloon sweep to clear stones and debris from the duct. There's no minimum requirement on the size of stones. All right, so again, we talked about this just earlier, not to be billed if no calculary debris are found. And you cannot bill it in conjunction with 43265, which is lithotripsy. That is considered part of the lithotripsy procedure. So this slide pretty well shows you the balloon extraction of debris. So as you can see, the balloon's inflated, and as it comes down, it's going to drag the stones and the debris with it. So 265 describes ERCP with destruction and lithotripsy, and any method can be used, and the removal of the stones is included. So again, 43264 is part of 43265. Lithotripsy device usually contains this. It's like a basket which traps the stones and brings them down. .43274 is ERCP with insertion of tube or stent, and that's the key in this description. Doesn't have an S behind it. All right, so each stent can be billed. All right, if more than one duct is stented, each can be separately billed. And actually, if more than one stent is placed, each one can be separately billed. So 2 stents in the common bile duct, you can bill 43274 on the first line, 43274 on the second line, with either the 76 or 59. We could also put the XS modifier in play on this one as well. Recommend that you put comments in your box 19 field so that payers know the location of each stent. These are some examples of what stents look like. You can see a plastic stent on the left side, the one in blue, and then the wire or the mesh stents that are on the other example. 43275 describes ERCP with removal of foreign bodies and or tubes or stents. It can only be billed once for the removal of one or more stents. So sometimes your docs will remove 2 or 3. Well, you could only bill this one time. And these are just some of the extraction devices. And some of your doctors will also use a snare. 43276 That is an exchange of a tuber stent into the bile or pancreatic duct. And that also includes sphincterotomy dilation, just like the insertion does. This also has duct in there. So if more than one is exchanged, you can bill each one separately. You would use 43276 on the first line, 43276 on the second. And again, you have the option of 76, 59, or XS. And again, like I said before, comments are very much encouraged. If one stent is exchanged and another new stent is inserted, then you can bill 43276 and 43274 XS or 59 with that, all right, because each stent can be billed. 43277 describes ERCP with balloon dilation of the ampulla and the biliary or pancreatic ducts and or sphincteroplasty. So each duct that is dilated can actually be separately billed with the 59 modifier or the XS modifier. If sphincterotomy is done to a separate biliary or pancreatic sphincter, we talked about that earlier, then that can also be separately billed with those appropriate modifiers. If incidental dilation is done with stone extraction, it is not separately billable. If ampulectomy is performed, this is considered an EGD with an EMR, since the ampulla is in the duodenum and not in the biliary tract. Now, that instruction is in your CPT book. May not be able to bill as an EMR if your physician does not document appropriately. 43278 describes ERCP with ablation of tumors, polyps, and or lesions. So these each have an S behind them. So it doesn't matter how many you do, you can only bill this once. 43273 describes cholangioscopy, otherwise known as spyglass when used with ERCP. It involves a separate instrument, which is actually a scope within a scope. And don't be confused with the term cholangiogram. Cholangiogram is an injection which is done with every ERCP and it's not separately billable. So make sure that you're looking at this very closely. It's an add-on code to any ERCP listed above, and it's not subject to the surgical reduction, so it should be paid at 100% of the approved amount. So this is a picture, several pictures of what the spyglass looks like. And as you can see on this one right here, you have the different channels, just like you do on the standard scope. This is a teeny tiny scope within the scope. Non-endoscopic cholangiograms. I know most of you listening don't do these procedures because a lot of these are done by radiologic intervention in particular. Sometimes you may be working with the radiologist. They usually end up billing this, and you bill your endoscopy codes in particular. But I had a question just last week on these, and I thought I would go into a little bit more detail, and I actually put the case study as number 5 in this handout. So when you look at 47532, it's an injection procedure for cholangiography, and it's new access, and what they're talking about is a percutaneous cholangiogram. So this is all percutaneous codes, injections. All right, so that means they're not being done through an endoscopic injection. It is through the skin. And then these are often the transcatheter codes are used by interventional radiologists. But again, we're also seeing some of our advanced endoscopy providers do these as well. They all include radiologic supervision, and there is no endoscopy code including in the descriptions of this procedure. So if endoscopy is separately performed, you can bill that with these codes. So 47533 to 47535 are talking about biliary drainage catheters, and these are percutaneous codes, all right? Some of them have an external, some of them have an internal and external, and some of them are a conversion of an external catheter to an internal catheter. Again, these are all through percutaneous access. The second one has to deal with the exchanges of the biliary drainage catheter and the removal of a biliary drainage catheter, and then the placement of a stent into a bile duct, percutaneous, including all of your cholangiography, etc. So all of this is included. Everything's included into one code. 47539 is placement of stents into a bile duct, percutaneous. All right, and that's new access. And then 47540 is a placement of stents into the bile duct, again percutaneous, with the placement of a separate drainage catheter. And then we have 47541. This is a rendezvous procedure, and I imagine some of you have heard of this. It's placement of access to the biliary tree and into the small bowel to assist with an endoscopic biliary procedure. If your physician actually does both of the actual access to the biliary tree into the small intestine and then also does the endoscopy with it, you would be able to bill 47541 with your endoscopy code. But if the radiologist does one part of this, they can bill the 47541, and your doctor, again, bills for endoscopy. Balloon dilations, endoluminal biopsies, removal of calculating debris from the biliary tract, these are all done percutaneous. Now we have biliary endoscopy codes. This is a percutaneous. The other ones, the transcatheter code, mainly are done by fluoroscopy. All right? So biliary endoscopy means you're actually putting a scope in through percutaneous access. So we've got all different codes for these, describe all the different therapeutic procedures as well. Biopsies, calculi, dilations, with and without a stent. So again, these are food for thought. We're not going to do a lot of these, but you will be doing some. You will be doing some of these procedures. And if you have any trouble with these, and I think a lot of times we do get asked some questions, we don't get a lot of questions on these. But most of the time it's because you don't have these codes loaded in your software system because they're not considered GI procedure codes per se. They're more radiologic. That may be an issue. So you may have to have your IT department load these for you if you can't do them yourself. So let's look at some case studies. So as we always do, you know, when we're looking at our procedure codes and we're looking at our endoscopy procedures in particular, we have tools of the trade that were required. We actually need the report. We're looking at CPT book, the HCPCS book. There's coding software out there to help us. CCI edits, Federal Register, modifiers, the ICD-10 book, any type of medical dictionary, and don't forget Google, Bing, whichever one you guys like and prefer. So when you're looking at an ERCP report, the very first thing you're looking at is it dated? So if not, don't proceed. Contact your doctor to amend the report, and I should say legally amend. Is there a preoperative diagnosis or indication? If not, or if it's not clear, contact your physician to amend it. The same with the postoperative diagnosis or finding. Does it say procedures performed or procedures scheduled? If it says performed and it doesn't list all the procedures, this could be an issue specifically if there's not clear detail in the body of the report. So most of the systems that we see for the endo writers and/or the providers don't necessarily update from the description in the endoscopy report. So this is often what's on the procedure note is what was scheduled and not completed. So does your doctor have all the procedures listed in the report? Is there a paragraph called indications and findings? And this is a good spot to put information as to how difficult this procedure was. And it also helps you to link the procedures to the diagnoses as well. The description of the procedure, how detailed is it? And you have to have an entry point. They have to tell you where it starts. They have to tell you how far the scope went, what instruments were used during the procedures, and the location of the different lesions or disease processes that were discovered during that procedure. Also, don't forget about making sure that there's a timeout or a patient identification also documented on the report. That seems to be a requirement that Medicare is looking at closely when they do review your reports, and will give you an error if it's not on there. Did your physician interpret the images and document that he or she was the only provider to personally supervise and interpret the images? If so, and if this is coordinated with the radiology department, with the radiologist so the duplicate billing does not occur. And the codes are 74328, which is the common bowel duct, 74329, which is the pancreatic duct, or 74330, which is the combination of both the common bowel duct and the pancreatic duct. And it's basically what was injected and visualized. There should be a separate paragraph to validate the complete interpretation, and modifier 26 would be added to these codes because you are doing the interpretation. You don't own the equipment. You're not doing this in your office. Was the note signed? And this is very important. Without a signature on the date, it is considered a false claim. It cannot be billed until the note is signed. And if this is a teaching facility, was there a statement indicating that the supervising or the billing physician was present during the entire procedure? This supports the modifier GC that you would add to the claim. So you want to always read the entire documentation for the service. Research any word or abbreviation not understood. Even if it's not clear to you, always go back to your doctor for clarification, and then also have them amend the report. Remember, if you have to submit a report and it's not clear to you, most likely the claims reviewer at the payer is not going to be clear to them either. Review the problem and highlight your diagnoses, your symptoms, or health status that just supports, justifies, or improves the medical necessity of any procedure or service before. I do this a lot when I look at notes for review, especially if it's a long note, and I know there's a lot of procedures that were documented in there. I will print it out, and I'll just look at it better this way. I'll highlight the procedures that were done. I will run it through a claim scrubber just to make sure that all of these are separately payable. And if it says that they're bundled and a modifier is allowed, they're usually talking about the 59 or the excess modifier in there. But just because it says it'll bypass if allowed doesn't mean you do it. It has to be a separate lesion and with a separate technique. So let's look at the first scenario. Scenario number 1 is Amanda ERCP. Indication, elevated transaminase, fever, chills, suspected ascending cholangitis. This is probably one of the few reports that I've actually seen that has all the detail in this and actually specifies the enzyme that was elevated. All right. It also gives you a differential diagnosis, what they're looking for in particular. So it has anesthesia. Prior to the procedure, a timeout was taken, which I was talking about just a little bit ago. Throughout the procedure, the patient's blood pressure, pulse, and CO2 and oxygen saturations were monitored. The video duodenoscope was introduced to the mouth to inject contrast to the bile duct. The ampulla was then cannulated. The guide wire was carefully advanced to the biliary duct, and a small amount of ICU dye was injected under fluoro. ERCP was accomplished without difficulty. The ampulla was status post-sphincterotomy, which means it's already been done. We can't bill it again. The bile duct was deeply cannulated. I personally interpreted the bile duct images with no assistance from the radiologist, which is the statement I like to see if you're going to bill for that. 74328, 26. There was a brisk flow contrast through the ducts. Image quality was adequate. Contrast extended to the entire biliary tree. Nothing was found. The biliary tree was swept with a 12-millimeter balloon. One 10.5 centimeter plastic stent was placed in the common bile duct. No complications and no blood loss. So as you can see, I have 2 codes highlighted on here, 43274 for the stent placement and the radiologic interpretation. All right, so we have your impression and we have your recommendations. And so technically what is billable is 43274 and 74328 with a 26 modifier. Only the stent insertion can be billed. The contrast injection is included. The patient already had a previous sphincterotomy. The diagnosis of cholangitis was just suspected and not confirmed. So really the abnormality of transaminase is the diagnosis for the stent placement. Now, as for 74328, as long as the radiologist does not also submit a charge, this would be correct. And again, we do have to double check with that. So just because we know we can bill this separately, we have to make sure that there's no conflict with another provider on this. Recommendation is that your physicians and the radiologist have a little discussion to see who gets the bill on this one. Because if both bill, whoever gets the bill in first gets paid. And if you get paid and the radiologist does not and their staff decides to file a complaint and do an appeal on this, if it's not clear in your report, you may end up having to pay money back. So again, we don't want to have to deal with this. We don't want to put this into an audit situation. So check first to make sure that there's no issues. Scenario 2, EGD, foreign body removal, pylori duodenal obstruction, ERCP with stent removal, and stone clearance of a common bile duct and the common hepatic duct. Successful removal of food and foreign objects from the pylorus, successful dilation of post-bulbar obstruction with a balloon, successful ability to pass the therapeutic ERCP scope beyond the obstruction to reach the stent. Successful stent removal, successful clearance of the bile duct from obstructive stones and debris, and successful occlusion cholangiogram showing complete removal of obstruction. This is one where actually all of the procedures were listed on the top of the report. Very seldom do I get to see that, and it's always nice to see. The initial scope was performed using the ERCP scope, but failed for two reasons. Number one, the stomach was distended and enlarged. And number two, there was clearly evidence of an obstruction and significant retained unchewed food within the duodenal bulb. The ERCP scope was then removed and the standard endoscopy performed using a rat tooth forceps and Roth net. Multiple pieces of carrots, potatoes, and other food were removed from the stomach and bulb. So that code is 43247, removal of foreign body. The patient was then re-endoscoped with the adult-length pediatric colonoscope, and under fluoroscopy guidance, an 8 to 10 millimeter wire-guided CRE balloon was used to cross the post-bulbar obstruction, which appeared benign. This was dilated from 8 to 10 millimeters and left inflated for 10 millimeters. So this dilation that we're talking about, it's not esophageal. It would be 43245. And 7436-26, which is the fluoroscopy guidance for our dilation services. This was withdrawn and the second balloon was inserted and again dilated with additional balloons. Then a repeat ERCP attempt was now done. And once the scope was in good position, the stent was grabbed with a snare technique and retrieved. Cannulation was then performed. Contrast injection showed filling defects within the common bile duct. A wire exchange was performed and a trapezoid basket was guided to cannulate the biliary tree. The stone fragments were then removed. A balloon was then inserted deep into the bile duct and multiple balloon sweeps performed, resulting in removal of multiple stone fragments until no further stone fragments or bile duct casts were removed. Cholangiogram showed no residual filling defects. The scope was withdrawn. The patient left in stable condition. So we have 43264 with a diagnosis of K80.51 because there was obstruction with the stones. And the 43264 was the ERCP with stone extraction. We have 43275, which was with the removal of the stent. And the diagnosis code used for that is D46.59. 43245 with a diagnosis of K31.5 for the duodenal obstruction. And 7436-26 with a diagnosis of K31.5 for duodenal obstruction. Now, even though the foreign body was done, the removal of the food, it's not billable with the removal of the stent. So when you put that together in CCI edits, no modifier will bypass the edit. So you're going to want to report the most extensive procedure, which would be the ERCP with foreign body removal. Number 3. ERCP with biliary sphincterotomy, removal of bile duct stone and sludge. Abdominal pain of suspected biliary origin, biliary dilation on CT scan, and abnormal MRCP. The bile duct was cannulated, contrast was injected. The middle third of the bile duct contained one stone, a few small defects consistent with sludge. A 12 millimeter biliary sphincterotomy was made with the traction sphincterotome. The biliary tree was swept with a 12 millimeter balloon starting at the bifurcation. Sludge was then swept and the stone removed only after balloon dilation of the duct below the stone. 43264, 43277 for the dilation. No stones remain on cholangiogram. Choledocholithiasis causing obstruction. Complete removal was accomplished by balloon extraction. Return to the referring physician in 1 week. You have 43264 with the diagnosis of K80.51 for choledocholithiasis and 4327759 with the diagnosis of K80.51. The sphincterotomy is bundled into the dilation code, and again, modifier 59 is required to indicate that it was not an incidental dilation. Number 4, jaundice, elevated transaminase, and choledocholithiasis. 2 large stones were found in the common bile duct. ERCP was insertion of the common bile duct stent. biliary sphincterotomy, removal of 2 stones in the common bile duct. Sphincterotomy was done to the same stent as stent insertions, so only stent and stone extractions can be done. All right, so the code would be 43274 and 43264. No modifiers required, and your diagnosis code would be K80.50 for choledocholitis. There wasn't anything to indicate there was an obstruction, and R74.0 for elevated transaminase. Number 5 is what I talked about earlier. This was the indication for the examination is metastatic cancer with malignant biliary obstruction. Procedure performed was ERCP with stent placement, endoscopic ultrasound-guided biliary drainage, and EGD with biopsy. So the scout film was unremarkable. The duodenal bulb was unremarkable. The duodenum was narrowed and showed an ulcerated hard friable mass. The ampulla could not be identified. The duodenoscope could not maneuver into the deep second portion, and attempted biliary cannulation failed due to the cancer in the medial duodenal wall. At this point, the patient's husband was contacted, and the option of an EUS-guided biliary drainage to palliate malignant bile duct obstruction was discussed. So the risk and benefits, the alternative of percutaneous biliary drainage was offered and discussed. The linear echoendoscope was advanced. The mediastinum was viewed. The pancreas was atrophic with a severely dilated pancreatic duct. The bile duct was severely dilated and strictured as a poorly defined mass seen at the head of the pancreas. There was ascites present. The gallbladder was distended, no varices were seen, and after using the Doppler to exclude intervening blood vessels, a 19-gauge fine needle aspiration needle was inserted and bile aspirated to confirm position. The contrast was injected, and cholangiogram obtained showed a severely dilated biliary tree with a stricture in the distal common bile duct. The needle was exchanged out. Over the wire, the Axios lumen opposing medical stent was advanced. The Doppler again was used. All right. The LAMS, which is the metal stent, was deployed with ease over the immediate flow of contrast and purulent bile. Over the wire, the stent lumen was dilated. There was free normobilia and an excellent flow of contrast and bile. Contrast was instilled into the bile duct to the confirmed placement of the duodenostomy stent and the absence of leak, and the pancreatogram was not attempted nor performed. The echoendoscope was removed and the gastroscope introduced. The esophagus and stomach were unremarkable. The pylorus was patent. In the second portion of the duodenum, the infiltrated ulcerated mass was seen in the expected region of the ampulla. Multiple biopsies were taken. So this was actually 47539 for the percutaneous placement of the bile duct stent, 43237 for the EUS guidance, and 43239 for the biopsy of the ampullary mass. So you would have the biliary obstruction code of K3.1 caused by the biliary carcinoma. All right, and that would be for 47539 and 43237. And then you would also be able to bill for the 43239, and the diagnosis would be based on the biopsy results or the pathology reports for the ampullary mass. And again, this is a very uncommon procedure. Most of us that are listening in, you don't see this. All right, so in rare circumstances, you're going to see this unless your physicians do a lot of these more complex, advanced endoscopy procedures. So some final comments and tips. And I think I've said this multiple times. If you're unclear on anything, your best resource is your gastroenterology provider. And they clarify it for you, then they should also do an addendum to the report to make it sure that it's clear for anybody that would get a hold of that report to understand what they did, where they did it, and for what reason. Make sure the indications for ERCP are clear. Make sure that the location of each stent is documented. Make sure that the indication for dilation of the duct is clear. Radiologic supervision can be billed provided there is a statement indicating personal interpretation. I also just made sure that there is no conflict between your physician and the radiologist, so dual billing is not done. Remember, guys, CMS also states that whoever interpretation guides the further care and treatment of the patient is the physician who should be billing for this service. All right, so your doctors do wait for their results. They're looking at it. They're not waiting for the radiologist to issue a report. So your physicians actually do have the right to bill for this. It's just making sure that there's no conflict. If you're not sure, look at the ERCP report. There should be a separate one. The hospital will bill for the technical part of it, and they usually will have on there that how much time was spent that the tech was present in the room for. And if there's also a detailed description of the ductal system in there, and it's signed by the radiologist, then you pretty well, it's a safe bet to say that they're going to bill for that service. But if you look at the ERCP report in the hospital, and it gives you the technical time, and then it says, see enterology report for interpretation, well, that should pretty well, you're clear that nobody's going to be billing it but you. So again, do a double check on this one. Go back to your providers, ask them questions if you guys are not billing for this already. Don't rely on the CPT codes or diagnosis codes that may be listed on the bottom of your endoscopy report. Some of your endo writers automatically do this. They're not 100% accurate, so always double check. If you see things that might be concerning or considered to be problematic, when I'm saying something that's very iffy, that your doctor might say, I don't care what the CCIs say, I want you to bill it anyway, don't hesitate to inform your compliance officer of this. Remember, for those of you that are listening in and you're certified coders, you are legally obligated. This is your license that's at stake as well. Keep up to date with any new LCDs by Medicare or any other carrier policies, and make sure to share that with other staff members, including your physicians. All right. So this ends the presentation, but I know we have one question over there. But before we go on with that, just make sure that you contact MJ for your CEUs. If you have any questions, my information is listed there. Okay, so one question that I see is that documentation for radiologic supervision, what is needed, and it showed something on slide 21, but I'm still confused. So guys, I think let's kind of go over this again. There's actually three types of fluoroscopy codes that I mentioned in the presentation. One was the standard baseline fluoroscopy code of 76,000, which cannot be billed with any endoscopic procedure. It's already built into your codes. The next one is the 74328, 329, and 330, which is your ERCP interpretations. We just talked about that just a little bit ago, and on one of the slides I specifically had that statement that your physician needs to say, I personally interpreted either the bile duct images, the pancreatic duct images, or the biliary and pancreatic duct images with no assistance from the radiologist. That's a statement that needs to be in there. All right, in order for you guys to really kind of, first of all, think, oh, maybe I can bill for this. If that's not in there, you can't bill for it. All right, so if you see that statement, then you know, okay, I have a chance of billing for it. Now let's make sure that the radiologist is in as well. All right, so again, the next one that we talked about was 74360, which is the radiologic supervision for the fluoroscopic guidance during dilation. All right, that is separately billable. All right, and the only information that has to be in there is to indicate that that was done, but there also has to be a static image showing what was dilated or where it was within the GI tract. So they have to at least take one image of that so it keeps it into the permanent record of the patient. Okay, do we have any other questions?
I don't see any hands raised. I don't see any other questions.
Okay.
I think we're good.
All right. Thank you all for listening. Have a wonderful afternoon.